have got some conceptual models that are applied in community health nursing. And when you're talking of models, models are very key. They form the foundation in which we can argue our point of view in nursing. And they normally give some directions when we are making a decision regarding some of the services that we offer in that particular community. So we can look at the first one. The first one is health belief model. The first one is called health belief model. So let me try to remind someone here to read now. Melvin Lusweti, you can read for us.
Concept mo- Conceptual model in community health nursing. 1. Health belief model (HBM). Origin: developed in 1950s by U.S. Public Health Service social psychologists. Core assumptions: behavior change influence individual perception and beliefs about health risks and beliefs. Key key constructs: 1. Perceived subspeciality, beliefs about vulnerability to a disease. Perceived severity, seriousness of the health condition. Perceived benefits of the efficacy of an action. Perceived barriers, cost, obstacles, or inconvenience to change. Call to action, triggers that
Cues,
prompt
cues.
you to action, triggers
Yes,
that frame changes, like media symptoms. Self-efficacy, confidence in ability to act. Application in nursing. Designing health promotion campaign, e.g. vaccination, cancer screening. Predicting preventive behaviors. Tailoring interventions to address barriers and enhance self-efficacy. Limitation: focuses mainly on the individual, less on the social and environmental factors. 2.
okay, thank you. Just at that particular point. Thank you, Lusweti. So, these are some of the. This is one of the model that is applied in community health nursing. Now, so when you're talking of conceptual, these are just concepts that are put together. Now, when you are looking at health belief model, this particular model, as the name suggests, believe, health, a model, health, belief, model. There is beliefs. What can you perceive regarding health? Now, what is the assumption? Now, the assumption here is majorly on behavior of people in relation how we perceive health, in the way we are able to believe in some of risks that we are able to incur in a particular locality. And what are some of the benefits when you take a positive action? Yeah. So we have got key constructs. Now, when you're talking of construct, these are just the building blocks. The building blocks of health, this particular health building model. It anchors on the following. 1. Perceived susceptibility. Now, when you perceive that you are susceptible, it is like you believe you can get a particular disease. Vulnerability is about the risk. How risk are you in a particular society? How risk are you? How can you be able to get a particular disease? And it is because of our behavior. When we change our behavior, so that we can be able to avoid these particular risk behaviors. Number 2, another building block, perceived severity. Now, it is about how serious the disease can occur. Now, we can be able to counter this through health education. Now, when you give health education, people will be able to know that when I'm able to get this particular disease, it is very, very important for me to be able to seek health service. Now, another structure or another building block, perceived benefits. Now, we believe in the efficacy of an action. When there is now seriousness, you will find that now this particular individual will be able to seek health service. Now, the benefit of it is now like preventing or treating that particular infection. Now, we have got another building block, perceived barriers. Now, as much as you can be able you can be able to go and seek a particular health service, but we have got also some obstacles on the way, like the distance, the cost of that particular service, the environment, maybe it is not conducive. Yeah. So it becomes also another challenge as much as you can be able to look for a particular service. Now, what can remind you? Cues to action is like a reminder. Now, when you for example, you have a condition like hypertension, so you will be able to feel things like headache, you are unable to breathe well. So those particular signs and symptoms, they are just like cues, signs and symptoms. They try to motivate you to go and seek that particular service. Also, there is what you call self-efficacy. Now we'll have the that particular confidence in you to take appropriate action. Now the disease is already there, and you have got the signs and symptoms like cues. So what will you be able to do? You'll be able to go and seek that particular service. So these are the building blocks of health belief model, and it is about behavior change. This particular, when it is linked to health education, when this health belief model is linked to health education, it brings about what we call behavior change in an individual.
Okay.
Yes,
Precede proceed model.
yes,
Origin developed
yes.
by Green and Keruta in 1980s. The nature is a comprehensive planning framework for health promotion and disease prevention. Precede diagnostic phase. Number one, social assessment, community needs, epidemiological, behavioral, and environmental assessment. Education. Number three, educational and ecological assessment, predisposing, enabling, reinforcing factors. Administrative and policy assessment, proceed, implementation and evaluation phase. Number five is the implementation and intervention. Six is the process evaluation. Number seven is impact evaluation, behavioral stroke and environmental changes. The outcome evaluation is number eight. That is the long-term health outcomes. Then application in nursing, community diagnosis, planning large-scale health promotion intervention, e.g. maternal child health and HIV and AIDS. Evaluation of public health programs. The strength is to integrates multiple determinants of health.
You can finish.
The limitation, resource intensive and complex. I think I finished.
Okay, thank you, thank you so much. So what we can say, it is that this particular model, basically, it is looking at the why, or behind health problems. Why are we having? It is talking about the why in relation to health. Now, so this particular model was developed by this guy here by the name Green and Creta in 1980s, and it was more on the precede is more on how to diagnose in relation to social assessment. Now, when you're talking of social assessment, we are talking at how to identify the social problems and the need of a community, be able to determine the desired community outcomes. That is all about the social assessment. Now, when you are looking at epidemiological, behavioral, and environmental assessment, it is about identifying specific health problems and their determinants. Now, when you're talking of determinants, we are looking at the risk factors. And within our environment, we have got many risk factors that can be able to make us to have a particular condition. And sometimes we go to the extent of saying, what are the causes? When you're talking about the risk factors, then what are the causes? Then there is what we call educational and ecological assessment in regards to predisposing factors, enabling factors, reinforcing factors. Now, yes, as much as we're able to look at it, so we normally look at, do we have the knowledge, the attitude, and the skills that is required for us to be able to tackle these predisposing factors or enabling factors or reinforcing factors. Then we look at the administrative and the policy assessment. Yes, we normally try to evaluate existing, yeah, evaluate existing administrative and regulatory measures, policies that are there in place. And if we have, do we have policy resources available to support the program when you're looking at the administrative and policy assessment? Then we move to proceed, implementation, and evaluation phase. So the first one is about diagnostic phase. Then this one is about now the doing and the evaluation. Now it focuses on the implementation. Implementation, it is about the intervention. Now, we carry out the intervention using the policies. That is what you need to know. We normally carry out the intervention using the policies and the regulations. What is regulating us to be able to offer a particular service? Then the process evaluation. So the process evaluation, we normally assess, we try to assess the program's process, the results and the outcomes to ensure that we have got effectiveness and we make necessary adjustments. So that is all about the proceed model. Now, how is it applied in nursing? Now, in nursing, it is applied in community health nursing to be able to do what we call community diagnosis. Now, community diagnosis, I know at some point you'll be able to do it now practically. I know there is an element of community diagnosis somewhere whereby we have got phases of doing community diagnosis. And when you're looking at community diagnosis, we normally talk of we try to explore. Then after exploring, we normally have what we call pre-planning. Then we plan, and then we do what we call intervention. Then after that, after the intervention, we are able to do what we call evaluation of what has been done by giving feedback to that particular community after doing the community diagnosis. Another thing where we can apply the proceed model is planning large-scale health promotion intervention like maternal child health and HIV thing that we can be able to utilize in nursing, or we can be able to employ this particular proceed model is evaluation of public health programs. So this particular, as you have seen in relation to my explanation, we do diagnostic, there is diagnosis, implementation, and then evaluation. So it can be able to assist us to find out if a particular program is working or not working at the end of it, after trying to employ it in a particular, or trying to ensure that you are trying to apply it somewhere. So you try to find out the weaknesses and the strength. Now, how is this particular proceed model essential? Now, we normally look at the strength. So we try to interpret multiple determinants of health. Now, when we're talking of multiple determinants of health, we are looking at biological determinant of health, the social part of it, the physical. We normally look at gender. We normally look at gender health. So those are some of the determinants of health. Now, limitation. It is resource intensive complex. So you need to have resources, enough resources for you to be able to partake this particular model. Now we have got another model. So who is this? Next is who? Crispin Parasa, you can read for us.
So we have the Donabedian model, the structure, process, and outcome model. Origin by Avi Donabedi 1966. It focuses on quality streams. So its structure, resources, system, and equipment, process, health, delivering of care to standards, and outcome community health results, satisfaction, quality of health. So its applications are quality improvement in benchmarking hospitals and community health programs, assessing its limitation. We have capture social demands of health.
Thank you so much, Crispin Parasa. So let me try to explain this. So the behind this particular structure, Avedis, Donabedian, 1966. So it has got components like elements. What makes this model? So basically, it has got structure, it has got the process. Now, when you're talking of the structure, as much as facility, resources, staffing, and whatever it is, so basically we are looking at the manpower. Remember, we know of the three types of resources. We have manpower, we've got the materials, for the money. Then we need also to have time. So the structure regarding this, basically at those particular areas, we are looking at manpower, we are looking at money in terms of the structure. And even sometimes what you call SOPs, standard operating procedure, they are very key for you to be able to come out clearly by saying that this is what I'm going to do. We need to have SOPs, and SOPs are very important because they will be able to guide you to be able to give quality care to the patient or to the client. So, and then after the structure, after ensuring that you have got the right structure, you have got the money, materials, manpower, you have got time, policies, SOPs are in place. Then you can now move on to the process. Now, process, we're talking of delivery of care, now the implementation. Now, we need also to ensure we are able to adhere to these SOPs, standard operating procedures. Then, as much as we are able to deliver these services, we are supposed to communicate within and outside, yeah, so that we can be able to have what is required from us. And then also, in addition to add to that, we need to comply. In the process, we need to comply. We need to ensure that there is time is followed to the ladder. We ensure that there is equity in delivery of that particular care to the people. As much as we are able to deliver in terms of we are looking at time and even equity, we need to ensure that those services that are safe for our clients, and we need to put our clients first at all costs. Then after that, we have got the outcome. Now, when you're talking of the outcome, basically we are talking of the patient and the community health results. Are the patient satisfied with the services that we are offering? Now, when you're talking of satisfaction, can they be able to come and even attest to it by having, we normally talk of exit questionnaire. You have got the initial questionnaire and then exit. What can they recommend about that particular service? Yeah. Now, in regard to this, also in relation to the outcome, this one will be also be looked at some of we normally talk of health indicators. Now, health indicators, there are very many. We normally talk of morbidity. Are we after having a particular maybe intervention in a particular community, have we reduced the number of cases? Do we still have the morbidity? Do we still have the mortality? So those are some of the indicators that we normally look at when we are looking at the outcome. And then lastly, quality of life. Are we able to ensure there is quality of life after offering a particular health service in a particular community? So this particular model is very important also in service delivery in a particular community. So how is it applied? One is about quality improvement in health facilities. Once this particular model is applied to the ladder or well, then it means we shall have quality improvement in health facilities. Number two, it also assists in accreditation and benchmarking of hospitals and community health programs. Remember, the accreditation is done by the government. Secondly, also, we have got affiliate bodies like Nursing Council of Kenya is also some of the bodies that can be able to assist even trying to do what we call accreditation of as a school nursing schools so that you can be able to train nurses. Then also, as much as it has got some merits, it has got some demerits, limitations. So it does not fully capture contextual and social determinants of health. That is on the flip of the page, whereby that is a disadvantage that it has. Now we can move to Neumann system model. The Bert Neumann, that is in 1972. This is the founder, the person, the person behind this particular model was called Bert Neumann. All right, let us see who is now in this particular call. David Wafula. No, before David Wafula, we have got Clinton Omboka. Clinton Omboka, are you in this call?
Yes, yes.
Okay, you can
So
share.
number 4. Okay, Neumann system model. That is Betty Neumann. That is in 1972. Core concept: client brackets individual, family, community is an open system interacting with internal and external stressors. Model components: we have 5 variables. That is physiological, psychological, social, cultural, developmental, spiritual. Lines of defense: we have a flexible line of defense, normal line of defense, lines of resistance. Stressors: we have intrapersonal, interpersonal, and extrapersonal. Nursing interventions: we have 3 of them. So let's start with primary prevention, that is reduce risk factors before illness, e.g. immunization. We have secondary prevention, that is early detection, e.g. screening, and tertiary prevention, that is rehabilitation and adaptation. Applications: number 1, disaster preparedness in community health. We have holistic assessment of populations. Then we have developing preventive nursing strategies. Strength: strength is to focus on prevention and systems thinking. Thank you.
Thank you so much, Clinton Omboka. So Neumann system model, the sender, the core person here is the person. You know, in nursing, we have got around 5 paradigms. But basically, let me just narrow to ourselves the individual, the patient. The patient here is the central person that Newman was talking about. And in the individual, we have got the internal issues that we normally look at, the internal resistance. That is the immunity that you are having. So we normally talk of let me talk of around 3 lines, 5 whatever lines of defense. So we have got flexible line of defense, the normal line of defense, and lines of resistance. So that is to the patient. So this particular model basically was talking about the paradigm of an individual in relation to defense. We are talking of the internal defense and the external defense. But as much as we have got the external defense, we have got some some factors, and these factors we normally refer to them as stressors. So we normally talk of the interpersonal, and extrapersonal stressors. Now, looking at this particular model as you are able to defend yourself. Now, the way you are training here as a BSN, as a community health nurse, at the end of it, how will you be able to assist this particular individual in that particular community? Now, that is what you are referring to level of disease prevention or nursing intervention. Now, at the moment, there is an additional, apart from primary prevention, secondary prevention, and tertiary prevention, we have got two other preventions that are there at the moment. So before primary prevention, we have got what you call primordial prevention. Now, primordial prevention is when we signal, like the government will just talk of, let me talk of, you see, smoking, maybe cigarette is, you see, creation of awareness. I hope we are communicating. Before primary prevention, we have got those particular hazards, or like they are like indicators, danger signs. So that is what we are referring to primordial prevention. Now, after primordial prevention, we normally look at the primary prevention, secondary prevention, tertiary prevention, and then another gap that is missing in this particular model is what we call quaternary prevention. Now, quaternary prevention goes beyond rehabilitation and adaptation. Now, it's about home visiting. It's about counseling that is beyond tertiary prevention. So I hope we are getting that particular concept. So we have got 5 levels of nursing prevention: primordial, primary, secondary, tertiary, and quaternary. So application is about disease preparedness in the community, holistic assessment of population, developing preventive nursing strategies.